Hello, this is Manny Ramos, your host of Rise Up, Real Issues and Stories of Every One of Us podcast. But first, let me talk about who we are. I'm Manny Ramos, a board member of PNAA and a past president of the Philippine Nurses Association of Central Florida. I'm a professor of nursing at Valencia College in Orlando and an adjunct faculty at William Patterson University. With me today is my co-host, Mindy Ofiana. Mindy?
Hello, Manny. Welcome,
Hi.
everyone. I'm Mindy Ofiana, Legislative Committee Chair for PNAA, Corresponding Secretary for PNAA Foundation, and past President of PNA Southern California. Before my recent retirement, I served as both as Chief Operations Officer and Chief Nursing Officer at one of the medical centers owned by KPC Group of Companies. We are honored to join us today on Rise Up, Dr. Carlos Irwin Oronce. He's a General Internist and Fellow in the Advanced Health Services Research Fellowship at the VA Greater Los Angeles Healthcare System. He is pursuing a Ph.D. in Health Policy and Management. He's a Fellow in the Specialty Training and Advanced Research Fellowship at the UCLA David Geffen School of Medicine. His research spans racial and ethnic disparities in health outcomes and quality of care, and evaluating the impact of policies and interventions to address the social determinants of health, and understanding the impact of value-based models of care for under-resourced patients and communities. Dr. Oronce is the president-elect for the Filipinx Community Health Association, also known as Fil-CHA. He is the author of the recent published opinion piece in Stat News entitled Health Disparities for Filipinx in Healthcare Are Disguised by Data Aggregation. Good evening, Dr. Oronce. Welcome to Rise Up.
Thank you for having me, and feel free to call me Carlos. I'm very happy to be here with y'all.
Hi, Carlos. So, what compelled you to become a physician?
Yeah, so, I think like many physicians, I grew up really interested in science. And I also kind of felt compelled, to help people. And I think those are like the two basic kind of guiding things. But my career path kind of was sort of a little windy in that actually through college, I struggled with the sciences. I actually didn't do very well in school and in undergrad and in college because the sciences were like so difficult for me. So biology, chemistry, I didn't do very well in those classes. And I actually kind of was struggling with wanting to pursue policy and civil rights. And I was actually more drawn to advocacy, especially in Asian American politics and thinking about Filipino American issues as well. And I almost didn't become a doctor, but it was actually in the third year of college. After my third year, I actually did an internship for an Asian American civil rights organization called OCA. And that's when I became really drawn to policy. And I thought, maybe this is the world that I want to go into. And then I ended up going to Americorps in Philadelphia right after college. So I joined, this volunteering group. I served in a federally qualified health center, helping patients get access to medication because they didn't have good prescription drug coverage or that they were uninsured. And thinking about how the patients that I was talking to, how sort of policies had failed them, how these other aspects of their social lives, like not being able to go to the doctor because the transportation was actually influencing their care. Like whether they got good care or not was based off of these things that were sort of out of their control and really shaped by these other issues. And then that's when I was like, maybe I do want to be a physician because I want to be somebody that like helps address some of these like gaps that lead to these really bad outcomes for patients that feel very, very preventable. And I found that I absolutely, even though I like loved thinking about policy and like sort of those structural organizational things, I also just as much loved talking to patients, and I think almost bearing witness to whatever was going on in their lives. And I think that was like really, really important to me. So that's a very long-winded way of saying sort of how I ended up getting into medicine.
I see. So what population groups did you work with at Americorps?
So in Americorps, I was in South Philadelphia. And the interesting thing about South Philadelphia is it is an incredibly diverse place with regards to Asian American communities. And so a lot of my patients were Indonesian, Vietnamese, and Cambodian. And so I often worked very closely with a lot of the translators and really got to know the patients and their stories because the translators were so close actually to the patients and got to be treated like they were family. And so the community there in South Philadelphia was just so warm. And I remember one lady who every time she would come pick up her medication from my office, she would bring me a bag of fruit. And it was just her gesture of saying thank you, even though she didn't, speak English very well. We kind of interacted, in sort of brief words and like sentences, but then she would always smile and give me a bag of fruit when she picked up her medication, and it was always so nice to see her.
Oh, wow.
So this was in Philadelphia. Now you're still very young, and I'm trying to think how younger were you then when you were in Philadelphia working with this minority group?
I was 22 at the time.
Wow.
So this was 2009, 2010. Yeah.
I see. So, Carlos, I always call you Dr. Oronce. So, how was your experience as a physician during the COVID-19 crisis?
Yeah. So my experiences were, I think, atypical compared to other physicians because, like you had mentioned, I was in the middle of fellowship. So my fellowship was mostly a research interdisciplinary policy fellowship. And my clinical time was actually about 10% clinical time. And so when the pandemic started, I just remember thinking this sort of uneasy feeling of like, oh man, the ICUs are going to get overwhelmed. The patients are going to come in, the volume is going to be really high. So I signed up to be on backup for the VA hospital. And somehow, fortunately, the VA did not need backup hospitalists. But I was prepared, if needed, to be a hospitalist. And so I was constantly keeping up with how to manage COVID. I was talking to a lot of my friends who were doing clinical work full time. And I was trying to see sort of where in the country, the trends were going in the wrong direction and what that might mean for Los Angeles. But ultimately what ended up happening is the VA really needed doctors who could do testing. And that's where the real demand was, because they were actually able to, in the hospital, stand up an entire unit that was staffed by advanced practice practitioners. So they had a lot of NPs and PAs that were staffing it. And so it was able to kind of multiply their kind of ability to take care of hospitalized patients, but they needed more supervision of staff in the testing tent. So in summer 2020 now, I was asked to do testing, and so we were seeing a lot of patients when I was there. I was still there on Wednesdays, and this was the second surge now, and so there would be patients coming in, A lot of them would be like mildly symptomatic. But my job was just to quickly assess them and see if they needed to be sent to the emergency room, or we could test them in the testing tent, which was in the parking lot at the VA.
Oh, wow.
Yeah.
So during that summer of 2020, when you were seeing these patients in the community, are you able to recall what was there like was there a pattern as far as the population groups that are more affected? I know LA is quite diverse, but was there like a an overwhelming pattern of population groups that are more affected than others?
Yeah. So one of the things about the VA patient population, for those, in the audience that don't know, when those who are patients of the VA come there, they have to have like some sort of service connection, is what it's called. So
Okay.
either they've served a certain amount of time, or they have certain injuries, or something that qualifies them to receive their care in the VA. And oftentimes the VA is a safety net in the communities where they're located. That is, they take care of patients who might be low income, who don't have as many, financial resources. And so the VA is there for any vet who qualifies and is service connected. And so in Los Angeles, we had a lot of vets who were also essential workers. Especially those who were like, less than 65, 70, who weren't retired. A lot of people still were working, and they tended to be essential workers. I remember testing somebody early on in that summer who mentioned to me that he was on a bus, and there was somebody that was coughing and not wearing a mask. And so he was just concerned because he had a runny nose as well. And I was asking more questions, and it sounded like it was a crowded bus. And for me, I was like, oh my gosh, how are they still packing so many people in the bus? And he was saying, like, we all had to go to work. That's what he was telling me. Everyone had to go to work. There was sick leave, technically, but it was very difficult for people to feel comfortable enough to take off work, because they felt maybe that the rest of the employees would be mad at them, or their boss would be mad at them. And so essential workers were a huge part. And I think a lot of patients that we saw also came from South LA. And if you think about sort of the geography of Los Angeles, South LA tends to be a historically Black community, and which suffered extremely high rates of COVID. And so that was another thing that we sort of saw was, yes, there were, racial disparities of who was getting COVID. And I saw that in the testing tent. And then one other thing that I also noticed was that there was also people who lived with other people, and that was also a cause of concern for why people were getting tested. So basically living with family, like, they had multiple people in the household, and they couldn't, socially distance. And they would tell me it would be like them and actually another family that they're family friends with, but because this person lost their job, they couldn't afford to pay rent. And so they were just housing this family friend for a little bit. And so you have two families in an apartment that really only fits one family, and one person might be sick. Everyone tries to stay away, but it's hard to do.
So, Carlos, how do you think the VA responded to these issues that you just mentioned?
Yeah, so I think the VA has responded particularly well to addressing COVID, at least within Los Angeles. And so I had seen the rollout of the testing tents happen really, really quickly and pretty efficiently. And I know that I should also qualify my comments and say that, my views represent my views alone and not of the Department of Veteran Affairs or the U.S. government. And, there was some issues with masks, but everyone had masks and PPE at the VA. I know that some of that was in the news.
Mm-hmm.
But I think in terms of other aspects of the response to COVID, I was incredibly impressed with how they were able to have backup hospital medicine services. And so I was third or fourth line, and they didn't even need to go all the way back to the third or fourth line because nobody really got sick. The attending physicians didn't get sick. The other thing that I thought was so impressive about the VA was the vaccine rollout. And so, like the rest of the country, they prioritized based off of age first and comorbidities. But what I saw in some of the data was that there was actually no racial or ethnic disparities in who got vaccinated in the VA system. And I think that was incredible. And a story that not many people hear about. We hear about the inequities in vaccination across America, but this is a really great example of where the VA was able to achieve equitable rollout of the vaccine, which is really, really impressive.
So, Carlos, in your article in the Stat News, health disparities for Filipinxs in healthcare are disguised by data aggregation. You mentioned that the absence of disaggregated COVID 19 data for Asian Americans has contributed to these disparities and hindered an equitable response for Filipinx. Can you talk more about this for our Rise Up listeners and viewers?
Yes, thank you so much, Manny, for that question. That is such an important question, and I think really speaks to a central issue that affects Filipino American health. And I think it's this being disguised in the data. And so what we mean by that is, so in the US, for Filipino Americans, for Fil-AMs, data are collected based off of one's self-reported race or how healthcare providers or healthcare system people like the medical assistant or the secretary record your race for the medical record. And so because Asian Americans include Filipinos and Fil-AMs and so on, we get lumped in with other communities such as Chinese, Japanese, Korean. And that means that when you look at data for COVID and you look at Asian Americans tend to, experience COVID at lower rates, are hospitalized less, lower mortality. And so one can then think, oh, well, Fil-AMs are doing well. They're not dying of COVID. The problem is, though, when you take a category as broad as Asian American that covers a huge continent, many, many countries that have very different histories of why they immigrated to the US and different healthcare systems at home and all of that, you obscure any of the underlying differences. And so everyone gets pulled into an average. And so I should say that the category of Asian American came about in the 1960s as a way to foster solidarity across Asian American communities that faced stigma, that faced xenophobia, and a lot of, essentially anti-Asian hate and violence. And so this was a way for people to band together to exercise political power and strength and say that our voices will be heard. And so that was a good thing. However, the downside is now, if Filipinos are doing worse in terms of health outcomes, compared to the rest of Asian Americans, that gets hidden in the data that get collected. And we saw that with COVID-19. I mean, I'll say that the National Nurses United report was huge, and I'm so glad that other groups were, looking at that information. I mean, the stat there is that even though Filipinos make up 4% of the U.S. nursing workforce, made up 26% of nurses who died in the United States. And we would have never known that if it weren't for folks who were willing to find that data. And I'll say one more thing on this, and that's part of the story of data aggregation is that it reinforces this idea of what's called the model minority myth, that Asian and Asian Americans are the good minority, that we perform well in terms of our income is good because we work hard, that our education rates are good because we put our head down and we have a strong work ethic that's because of our culture. But that ignores the fact that certain immigration policies allowed certain immigrant families to come to the U.S. And so that's what shaped that perception. But it was really, really useful for, I think, broader American culture to help make sense of race relations as if they had a good minority. And so that really reinforced this idea that Asians don't have problems, and that extended to health. And so there's a common misperception that Asians don't have health problems. But you look at the disaggregated data for communities, and you see Fil-AMs with high rates of hypertension, diabetes, and we don't receive money. If there's no recognition of the problem because of data aggregation, there's no belief that there is a need. If there's no belief that there is a need, public health and policymakers don't give the money to address the problem. If we don't address the problem, those differences in health outcomes continue. And so that's what I meant when data aggregation directly contributes to the persistence of those disparities.
So why has the impact of COVID-19 on Filipinx and other Asian communities has been ignored, even though we make up the fastest growing racial groups in the United States?
Yeah, so that's a great question. I think that really also speaks to this idea of the model minority myth and the absence of data. And I think it's a evergreen issue that has been going on for years now. It came before COVID-19. Some of the scholars that I've always kind of admired from afar have been talking about data disaggregation as like the first step that is necessary to ensure that Filipinos, Filipinas, Filipinx, people, their issues are actually made aware. If the NIH, the National Institute for Health, doesn't even recognize our community as a community worthy of further research, then that means that interventions, things like hypertension programs, education programs around diet, exercise that maybe work for other communities, we're not studying if they work in our communities or if there are ways to make it better. And so like that contributes, directly to the lack of attention on the issue. Yeah. I don't know if I completely answered your question, so feel free to follow up there.
Right. So so I hear this that it's really very, very important to obviously aggregate the data and get more information about the Filipino community. How have they been affected by the COVID? And I think it goes beyond COVID moving forward, right? If we will continue to somehow track the data and follow up. Do you have any idea? I do know, for example, that in Hawaii they do segregate their data, right?
Disaggregate.
There's data for Filipinos, Koreans, Japanese Americans. Um, is that true for the mainland USA?
So in some places, um, disaggregated health data are available, but they're very, very difficult to come by. And so, for example, in California, the data that is disaggregated for Asian Americans was only available from request. So Ninez Ponce helped get access to the data because she had asked for it, and I think that was a key thing was being able to ask policymakers to release the data. But if that data isn't just out there, like, people aren't going to know, right? And so you want data to be as in the hands of community members and like as easily accessible as possible, because they're the ones that are most affected by it. For me, like somebody who also is like in like an academic medical center, like, I shouldn't be the person who has supreme rights over looking at somebody else's data. This belongs to the community. And so California, actually has a law on the books that they're supposed to disaggregate data in the future. But I believe it doesn't get implemented until something like 2025. But the more that we can have the disaggregated data, where we can say, for hypertension or for COVID, what is the prevalence or the proportion of people in the Filipino community or the Korean community or the Japanese community that has high blood pressure? That is knowledge that needs to be available for everyone. And so I think California is taking the lead by having an actual policy. I mean, Hawaii has it immediately available, but other states kind of have to follow suit as well and do the same in order to make sure that this doesn't happen again. You can see that if you don't have data in real time, you can't react in real time. I mean, people have already died. People in our community have already died, and we don't. Now we have the data, but that doesn't help the people who have already died.
Right.
So we are both executive board members of Filipinx AO Community Health Association. I joined just last year. It's been formed. Can you tell us when, how, and why did it get started?
Yeah, so this all started last year when I think the sort of groundwork was laid when Dr. Ninez Ponce, actually now one of my mentors, started to circulate a letter with, I think that was also co-written by Dr. Ryan Huerto, who is he's a family medicine physician in Oakland now, as well as Aaron Manila Pedro, who is a Ph.D. student in public health at UCLA. And they actually have written about this as well, and other people in the community about how concerned they were that there were all these news stories that Filipinx, Filipino American nurses were dying at such high rates. Yet in the National Academy Medicine report on the ethical guidelines for how to give out vaccines, that among priority population, Fil-CHAs were not there. And so how is it that, more than 6 months into the pandemic, we don't really have a good idea of who's dying from COVID because the data aren't there, but you have news story after news story after news story in places like Stat News, in NPR, in CNN, NBC News, where they're interviewing Fil-CHA nurses who are saying people are dying. One of the first nurses to die in Los Angeles was Filipino at I believe Hollywood med center. And and so when that letter got circulated, that started, I think, to get energy and consciousness and awareness within the community, because it was originally started by people that then ended up in other clinicians and other circles, and that was submitted to the National Academy of Medicine. And then 2 months later, I had heard Ninez speak on a panel with Don Operario, who is the director of the Philippine Health Initiative for Research and I believe scientific training. Brown First is the name of the group, and they're based at Brown School of Public Health. And so he was a panelist. Ninez was a panelist, and so was R.J. Tagueg, who is a sociology Ph.D. student at UC Davis. And so I heard them speak on the experiences of Phil-AMs in COVID, and it was incredible to me, hearing them speak. So Dr. Operario and Dr. Ponce had talked about it from like a public health quantitative side. And then I had learned that RJ was doing these, what he called kwentuhans, which were just oral histories throughout the pandemic, talking about sort of the experience of people in the Phil-AM community who were experiencing hardship, whether it was because their loved ones were working on the front lines, whether they were having, trouble with school because they were home from college and they weren't connected to people, or they realized that other loved ones were in the hospital now with COVID. And so there were people all across the country who were expressing sort of frustration, grief, sadness around COVID, realizing it was affecting the Filipino community. And, I was asking Ninez, like, is there any venue that brings people together to talk about these issues more nationally? And the Obama administration, or the Biden administration is going to be coming in a few months. I think that there's an opportunity to potentially raise awareness around sort of our community with a political administration, a presidential administration that might be more sympathetic to sort of the concerns that we have, especially when they appointed Marcela Nunez-Smith, who is a physician, to be part of the COVID-19 task force for the transition of the Biden administration. And so that's what got the ball rolling. And Ninez has a huge network in the Phil-AM community as well, and she sent emails out to people, and we wanted to make sure that we were reaching out across all clinicians as we were thinking about how to respond to sort of the Biden administration. So we reached across, obviously, to nurses, other physicians, people who were like outside of those two fields, like physical therapy, occupational therapy. We were also reaching out to traditional public health practitioners, so people who are epidemiologists. And we got everyone in a room, and this is how the Filipinx AO COVID-19 task force began. We wanted to also involve people outside of health. And so we brought in Lizel Tanglao, who was in charge of the COVID-19 response for Fil-CHA, the Filipino Young Leaders Program. Mindy, we brought you in. We brought Jenny Aying. And so we wanted to get everyone to brainstorm together. And I think that's where the strength in numbers and strength in different perspectives comes from, is you have everyone in the room thinking about, how to respond. And so I had worked with Alex Adia, who's an MPH, and we drafted this letter in response to Marcela Nunez-Smith, and we worked on it for actually a couple of weeks and really wanted to get consensus. And we sent it out in January after getting like 500 signatures within a day or two from across the country, and that was incredibly impressive. And we fired that off. And that's really sort of the origin story of how Fil-CHA began, and we went from there to think about how to magnify our impact, how to do other programs, how to continue the pipeline of clinicians and students who are interested in addressing, the health of the Fil-Am community. So it's been an incredible experience to see this grow over the past year.
So, Carlos, what we know is that for people who have more comorbidity, right, like hypertension, obesity, heart disease, they were the population group that had higher risk, right, of dying from COVID if they got infected. So, how does that relate then, or what do we know about the Filipino community and the Filipino nurses? Because they are the frontliners. They were the ones who were directly working with these COVID patients. Do we know anything yet about the Filipino nurses' risk or the Filipino patients or population group in general? Are there studies out there looking into that at this point?
Yeah, so that is a very, very important question. And I think there are kind of multiple ways to look at it. First, because we don't have disaggregated data, it's hard to have really firm, consistent conclusions about Fil-Am health. But I will say that in the places where disaggregated data have existed, we have had really good insights on Fil-Am health. So one is the California Health Interview Survey, which actually Dr. Nunez Ponce helped start, and is a survey in California that asks people about their health risk factors. And that's how we were able to know that Fil-Ams experience higher odds of hypertension and diabetes. And that was an article that was published in the American Journal of Public Health, I think 2 years ago, actually by Alex Adia. And there's another great group out of New York, the Center for the Study of Asian American Health, or CISA, and they've done some disaggregated data work as well. And I believe some of their investigators have done work in the community, working on high blood pressure in the Fil-Am community. There's another really important study that looks at let me take a step back. So I'm a big proponent of understanding the social determinants of health. What are, aside from physical drivers of health or physical risk factors, things like smoking and obesity and not being able to exercise, those are the traditional risk factors we think of. But if we look more upstream and we look at sort of why people smoke or why they might have a higher weight, there's all these social factors. And I think that's a part of what is going on with the Fil-Am community, especially among nurses. And so there was one really important study published last year from Jen Nazarino and Catherine Sinisa Choi and Alex Adia. So I'm sure many people are familiar with Catherine Sinisa Choi's work. Her work actually influenced me in college. I didn't know anything about the history of nurses, Filipino nurses, until I read her book. And it's still on my bookshelf. It's underlined heavily. And so when I saw this paper that she wrote last year, my attention was immediately drawn. And so it speaks to the power of social determinants of health, because what they looked at is nurse burnout during the, not during the pandemic, it was all before the pandemic, but they looked at nurse burnout and who changed jobs and who didn't, comparing Fil-Am nurses and white nurses. And, what they found is Fil-Am nurses tend to be in inpatient settings. They tend to be in the ICU settings. They are more likely to stay in their current job, even when they are burned out, compared to white nurses who tend to go into outpatient settings. and the pay is better, but what does that pay? Why do people want higher household income? Why do people need more income? Maybe they're sending remittances back home. Maybe they're supporting their parents back home. Maybe they're helping put their sister's son through college in the Philippines. And so that's like another part of the story that people can't really find good information on, but that's part of it. If more people depend on you, you're going to be working in these tougher situations, but the pay is better, and but it's more stressful.
Right.
And we saw that in the stories of Filipino nurses in the pandemic. I just remember hearing the story of one Filipino nurse who ran into a room when somebody was coding and she didn't put on PPE. And that was, speaking to her dedication to her patient, but it's the stressors of these jobs that increase the risk. So when people are more stressed out, they have higher risk of high blood pressure, higher risk of diabetes. And this is all because, they might be working in a high stress nursing job that was available and brought them here, but they have to support family back home. And so, it's all connected with some of this history that Ren probably discussed last week. And then I think with other risk factors like hypertension, we definitely need more studies. There's been a few large epidemiological studies like that I believe are published in the Journal of the American Heart Association that looked at the number of years of life lost due to premature coronary heart disease and stroke, and they were really high in the Fil-CHA community, much higher than other Asian ethnic groups. And we can say that this is also due to diet, but why is the diet bad? Bad? Maybe the diet is the way that it is because American processed foods, are available in the Philippines and became popular. And so we have to think about some of that colonial history as well. And I think in terms of some of the cultural factors that might also be contributing, I was moved very much by one of my friends' work. So Dr. Antonio Moya is a neurologist here in Los Angeles, and he was in my fellowship the year ahead of me, and he did these focus groups with Fil-CHAs here in Los Angeles, and he found that the power of bahala na, and it was a major factor in why people didn't call 911, when they were having a stroke. And so that inspired him to develop a commercial that was on TFC that encouraged people to call the ambulance. If you're having stroke symptoms, don't wait. Time is brain. And so I think there's multiple reasons why these health disparities exist, but we need more research in order to have a better understanding than what we have now.
I want to go back to the what you mentioned about a while ago, a letter that we sent to the COVID-19 advisory board for the Biden-Harris transition, right? And I know that PNAA is one of the 500 signatories that we got within 200. Do you think we achieved the intent of the letter?
That's another really good question. I think in terms of the specific ask in that letter, we wanted there to be somebody from the Fil-CHA community. Specifically, if we ever got to that stage, I was going to say we need to put up somebody from PNAA or recommend somebody from PNAA to be a member of that task force. That was something that a lot of us were talking about, and it needs to be a nurse. And we didn't get a response, and that was really disappointing. And so we weren't able to achieve those short-term goals of getting somebody, on the board of the transition, the health equity task force, or even a acknowledgement that this was affecting the Fil-CHA community disproportionately. But I think despite that, I think what resulted afterwards is our community came together across professional groups, across people from different parts of the country to strategize how then can we amplify our impact and prevent this from happening in the future. And I think, our eyes on what can we change in future policy. One of the things is we can implement data disaggregation as one piece of it. We can continue to advocate for that PPE, union protections. Nursing unions were one of the biggest factors that helped actually ensure patient safety. So that was another major thing. And as we've talked about in Fil-CHA, the next step, we need to make sure that people are interested in public health in the Fil-Am community. I wear a hat as a clinician, but also as a public health researcher. And so as a clinician, I love taking care of patients. And I love thinking about what are ways that we can improve, Fil-Am health. And my public health researcher side says, how do we get more clinicians? It's important to be at the bedside, but how can we get more clinicians to think about public health to amplify the impact and the issues in our community so that they can get heard? And so, as we've kind of talked about in Fil-CHA, one of the ways to do that is to invest in our young people.
Mm-hmm.
And I think there are people in in college now who are interested in nursing, but are also interested in public health, who are interested in things like being a midwife and being a physician, and also going into public health. And if we can get some of those bright minds in the right places and give them leadership skills and help get them, into the next administration, then I think we're able to accomplish a lot of the things that we wanted to do with that original letter for the next big crisis that might affect our community.
So, Carlos, for the agenda to disaggregate data and get more information about the Filipino community, what do you think is the biggest hurdle right now? And which agency do you think we need to somehow reach out to among the agencies? Who do you think would be the priority agency to approach regarding aggregating data and to get what we need as Filipino Americans?
Yeah, I think Health and Human Services is like the big one, right? Because Health and Human Services is the department under which Centers for Medicare and Medicaid Services lives, the CDC lives, the Health Resources and Services Administration lives. And so if HHS can have a policy, then that is a huge, huge impact. I think that is also, while that's important, we also have to think about states. And so for places like different PNAA chapters, think about what's going on in your state. So California was able to pass a law that has data disaggregation. I think it's AB like 1726. But if different, maybe other chapters around the country look at AB 1726 and figure out, is there someone in your state that's working on a piece of legislation that looks like that? Then maybe your state can make it a requirement that healthcare systems, healthcare providers ask people about their race and ethnicity in a disaggregated way. They ask them what specific community you belong to. So I think that those are very important kind of policy levers to act on.
Dr. Oronce, Philippine Nurses Association of Southern California partnered with you last June of 2021 as volunteers with your community coalition COVID-19 vaccine pop-up event. Was that successful, or what are still the challenges of vaccination and boosters, and for the vaccinations for ages 5 to 11.
Yeah, so that was actually one of my favorite events last year, of being involved in, and I think really speaks to the power of the PNAA community. And I remember being concerned about not having like enough volunteers. And I remember getting like an email from like Catherine Rubio, and she was like, "Oh, we have a lot of PNAA Southern California members who are really interested and heard about this event." And they rolled deep. Like I think like six, seven people. Like we didn't even need that many, but I said everyone come just in case, and it was so helpful. And one of the funnest parts was like, I had never done anything like this before. A lot of the people involved, we haven't done anything like this before, and we just partnered with this local federally qualified health center. And so all the boxes get rolled in from the staff from the clinic, and we open up the boxes and I don't even really know what to do. And then I turn around because I was going to go get something else, and I turn around and the PNAA members, I thought of them as all my titas and titos are over here. They just start unpacking everything, and in 2 minutes everything is set up perfectly, and it was the best thing ever. And it just spoke to the amazing power of having community there and having so many groups there. And so I thought it was a great success.
Thank you. So, Dr. Oronce, this is going to be the last question for you. What do you want to tell our listeners and viewers that we have not asked you?
Oh, that's a wonderful question. I love that question. We covered data disaggregation. We covered the policy response. I think that it is going to continue to be really, really important that for the Fil-AM community that we continue to communicate and engage with each other consistently. And that's what I have always loved about Fil-CHA, that we have physicians there, we have PNAA members there, we have PhD students there. And I think if people across the community continue to talk to each other, and we talk to the policy people who want to work in the administration, I think these are really, really important ways for all of us to continue to increase our impact. I know it's a cliche to talk about, but there's that stereotype of crab mentality, in the Fil-AM community. And but what I love about how our community has responded to COVID is the complete opposite. We're always finding ways to help each other, boost each other, amplify each other's work. I mean, we see that with groups like the Council of Young Filipinx Americans, CFAM. We see that in Fil-CHA, PNAA. Everyone is retweeting and amplifying each other's messages about how do we address COVID in our community? How do we prepare for the next major crisis? And how do we push for this vision of true holistic well-being for our community, because we deserve it. It's time for us to stop saying that we don't deserve wellness, and we need to keep putting our heads down and working hard in this country. And sure, that's important, but caring for each other and addressing these challenges is of paramount importance. And so that doesn't respond to a question, but it just kind of reflects how I'm feeling right now.
Continuing to support, engage, lift, and care for each other. Thank you very much, Dr. Carlos Irwin Oronce. And I also want to thank our co-host, Mindy Ofiana, our director and producer, Rodney Cajudo, Caro Robles, PNAA Chair for Communications and Marketing, our advisor, PNAA Foundation President, Nancy Hoff, and our executive producers, PNAA President Dr. Mary Joy Garcia Dia, and our PNAA Executive Director, Carmina Bautista. Join us every Wednesday here on Rise Up. Until then, keep on rising. See you next week.